What if everything you thought you knew about joint pain, chronic disease, and even aging was just the tip of the iceberg? Today on WellWaveNOW, we uncover how regenerative medicine is helping people heal in ways most never imagined, beyond joints, beyond sports, into a whole new world of possibility. Our guest today is Dr. Ethan Kellum, orthopedic surgeon, regenerative medicine innovator, and founder of the Kellum Stem Cell Institute. Dr. Kellum has treated everyone from elite professional athletes to everyday people living with conditions like autoimmune disease, neurological disorders, and even heart and lung disease. In this episode, you will hear what sets his approach apart from the standard treatment, why he believes in using your own cells over donor cells, what he has seen work for older patients, and how regenerative medicine is redefining prevention and healing. If you ever wondered whether there is more that can be done for your health, you will want to stay with us for this conversation. Welcome to WellWaveNOW, your portal for actual wellness insights. We, Breck Rice, Dr. Bob Levine, who's unable to join us today, and I, Tim Daniels, are your wellness catalysts, committed to elevating your health, enhancing your functionality, and optimizing your performance at every life stage. WellWaveNOW, where timeless wisdom lights your wellness path.
Hey, Dr. Kellum, welcome to the show. It's great to have you on.
Thank you so much for you guys. I appreciate it very, very much.
Yeah, we look forward to jumping into this. So let's begin by hearing about, how you first started your practice because you were in surgery first, right?
Yeah. So that's a great question. And I was like most orthopedic surgeons. I finished residency, went into a sports fellowship, and then thought I was going to come out and operate on all the ACLs and rotator cuffs. And so I came out and went to work for a practice and taking call and doing all that stuff that you normally would. And there was just a couple of things that kind of happened along my way that opened my eyes just to different things. And so I was doing the very typical, see a million patients, do a million surgeries, take all the call. And I had three patients in particular that helped me to kind of see things differently. I had a patient that came in. He was a runner, and he had been seen by three other orthopedic surgeons in town. He comes to me as the new guy on the block, and what can you do for me? What can you do? And I literally looked at him and I said, "There's nothing I can do. You've had all the treatments for your Achilles tendonitis. You've been in splints and boots, and you've seen physical therapy. You've done all the stuff." And as I walked out the door, I said, "Well, there's this thing called PRP that I could do for you. Insurance doesn't cover it, and I don't know if it's going to help you at all." And so that was the very first patient. Treated him, and he went back to running marathons.
Oh, wow.
And then I had a patient that had a knee scope or bilateral knee scopes by me. One knee did well and one didn't. And so it kind of had me thinking, well, okay, well, what's the deal on this? 2 or 3 year old female that had knee pain, very classic kind of deal. And MRI showed meniscal injury, meniscal tears. And so I went and scoped both of those partial meniscectomies. And, like I said, one knee did okay, and then one did horrible. So that had me thinking. And then I had a lady with kidney disease that couldn't have surgery. And so trying to figure out things for her. So those are the things that got me started down this road as far as understanding I have a problem and I don't have a great solution. But hey, I learned the solution, and I learned the solution in fellowship. I was very fortunate to go to New England Baptist Hospital. Didn't want to go there, but so thankful that I did because it was a very busy surgical practice. And the only reason I didn't want to go there is because I'm a Southern kid and I didn't belong in Boston, is why I didn't want to go there. But within 2 weeks of being there, I realized that this was the best place for me because, I did about 1,200 surgical cases there as a fellow. That's me personally. And there were four of us fellows. And so
Wow.
surgically, it was, and if you compare, there's a fellowship in my town where I live now. I'm in Nashville. That's Premier, and their fellow does about 400 cases a year. So you can, you can look at, I could do an ACL in my sleep. But it was during that time, even though it was the volume of surgery that we were doing, my attendings there, we were the team position for Harvard Athletics, Tufts Athletics, Mount Ida, but also for the Boston Celtics. And because of those things, those guys were looking for regenerative medicine in the form of platelet-rich plasma or PRP. Kobe Bryant had put it on the map in 2009.
Hmm.
And so those players wanted those things. Now, my attendings didn't care so much about it, but they did it because those guys wanted it. And so therefore I learned it. And it wasn't really until my second year of practice that that patient came my way and I treated him. And then I just started doing more and more and more until now my practice is completely based upon those things.
All right,
That
good.
was quite the transition for sure. I mean, absolutely. I think, and when you said you did that many surgeries, I'm like, yeah, you probably could do those, and an ACL
Oh,
tear in
yeah.
your sleep now.
All right, hold on a second, Bob. So I spoke too soon. Dr. Bob is able to join us here, so good to have him with us. And so, Bob, I asked your question there in the second there. But you mentioned you started with PRP, and that told you down the track. You defined what it was, the platelet-rich plasma. But what really is that? Because that's still, in my opinion, still isn't out widely known out there in general as to what it is. So can you explain what that is, Dr. Ethan?
Yeah, yeah. So the blood has two components in there. It has solids and it has liquids. The solids are things like white blood cells that fight infection, red blood cells that carry your oxygen, and then platelets. Now, most of the time we think of, when you mention platelets to us as just people, right? When we say platelets, we go, well, those are the ones that cause things to clot, right? And we go, very true. That's what platelets cause things to clot. And normally it kind of stops there, but if you understand why that clotting happens, it's because of the growth factors in the platelets. And so what platelet-rich plasma is saying, okay, we're going to get rid of all those other solids, the white blood cells, the red blood cells. We're just going to keep the platelets, those solids, and then a little bit of that liquid, the plasma part. I didn't define that earlier, but
Mhm.
the liquid is the plasma part. And we're going to take all those other things out and we're just going to leave those platelets and a little bit of that plasma. And it's those growth factors that help with healing, decreasing inflammation, all those things. It's a very natural thing within our body. And it does all that stuff, whether it's going to cause a wound to heal or cause a clot to be formed or what have you. There's these, other things in there. These factors, once again, they have names like platelet-derived growth factor or vascular endothelial growth factor, or, all these different things. But those growth factors are inside those platelets.
Yeah.
Yeah.
Thank you. Okay, Dr. Bob, you had something?
Very nicely explained. So you said your practice became centered around all those things, but so what are all those things? Because I just heard PRP and there's probably a million
Yeah.
other stuff. What
Yeah,
else?
so when I initially started doing these things, it was platelet-rich plasma or PRP that I used, and also I did use some off-the-shelf products, and that's a very interesting story too, kind of how that happened. But then it morphed into using stem cells from bone marrow, stem cells from adipose, which is fat tissue, and then there's been derivatives of those things, like the FDA doesn't like you to say. Uh, uh, Exosomes, but most people know them as that. I say nanoparticles, which are small packages of information that come from stem cells. And so so it's morphed into that. So you have some what we call autologous, meaning from the patient, and then we also have some of the allogenic, meaning from someone else. But all of those different things, and the two big categories are going to be stem cells, and then growth factors, and then you have some other mediators too that can be helpful. But that's all those things.
All the biologics. And
Yes.
Thanks for explaining that. And by the way, your communication skills are outstanding. I mean,
Uh,
really, I can understand exactly what you're saying. All the details is beautiful. Thank you.
no, good. Thank you.
and we'll circle back around to that a little bit here. But now you mentioned like the Harvard, and now all these people mention Harvard. Like we have another doctor on. She's so proud she went to Harvard. But I will preface this in that one of my sisters went to Harvard, but then I will add to that she finally saw the light and went to Stanford for her graduate work. So now,
She just
if you were dealing with the Stanford athletic team there, then I'd really apply. But I'll let it go with Harvard for now.
listen.
We got a lot of
Listen,
bias going on here.
Listen, your
Uh,
sister she just keeps getting better, right?
yeah,
That's
that's right. But now with the Celtics, and you mentioned Kobe Bryant put the PRP on the map, and I hadn't realized that. But a lot of that is associated with the knees and the joints and the help in that regard.
correct.
And I think we want to get to people early on that the work you're doing goes beyond that. So what you're seeing with the PRP and the stem cells and I'm not a doctor, so I'll say exosomes here. You could stay out of trouble and say nanoparticle and on that. They're getting expanded usage or have a wider spread usage, and even in your practice. So can you say what else are you And I think you alluded to it, somebody came in at one point, but what else are you kind of using the biologics on,
Yeah,
Doctor?
yeah. So, as an orthopedic surgeon, right, my love is tendons and bones and joints and ligaments and spine and those things. And as my thoughts of disease model has changed, going from not just structural malfunction, but also this idea of, hey, inflammation.
Mhm.
And and when you apply that not only to musculoskeletal disease, but then you say, okay, chronic disease has to do with inflammation, it makes a lot of sense that these things can be applied to that. So you name it. I mean, heart disease, lung disease, all those things have a component of inflammation for that. Autism, multiple sclerosis, dementia. Uh, they're all of those things have components of inflammation that are there. And so,
Hold on there, Dr. Ethan. I'm with you all the way until you said autism. Now, so talk to me about autism and inflammation.
yeah, I think,
Tim won't let anything go. Go, Tim. You're not
yeah, no, I very much believe that there is a component of inflammation that is a part of autism that will, decrease how the brain function and works. And nerves and then how that affects behavior and processing and all of those things. I very much believe that, and I think that that's proven in the literature. Not That's not anything new with me, or that I would say that anything's controversial about that. Um, any disease that you think of has that component of inflammation to it, and definitely I would say that autism does.
Yeah, and I would say that autism is linked with changes in the immune system and
Yes.
the ability to fight off disease, and so inflammation plays a key role in that.
And as you mentioned there, and that's like, so when you go down that road, it all leads back to the immune system.
Yeah.
When the immune system is high or the immune system is low, both of those will cause disease, inflammation, and issues. And the interesting thing about stem cells and the interesting thing about growth factors is that they have a way of saying, okay, if things are high, I'm going to make you normal, and if things are low, I'm going to make you normal. And resetting those things in some ways. And so it really, at the end of the day, has to do with inflammation by regulation of that immune system.
So, Dr. Ethan, when you're treating conditions, to walk us through what a typical standard treatment plan would be, and then what is the patient hopefully expecting for an outcome?
Yeah, so it's one of those things, and I tell people this all the time. I have a practice that is built upon customer service and education. That's what we do. Now we do it in the way of we're stem cells and regenerative and all those things. And so my two goals are this: number one, to make a patient to feel seen and heard, and then number two, to educate them about what I know. And so when someone comes in with whatever problem that may be, and I'm one of those guys that I don't limit myself to something. Now there may be something that I don't do well or I've never done, and I'm always very forthcoming and honest with those things. But when people come in, my deal is to understand what's going on with them, and then to say, okay, does what I do, can that help what's going on with you? And so my hope is to first of all do those things, make them feel seen and heard, educate them. And I hope through that, then we could potentially um, um, make the symptoms that they're feeling from whatever disease process that they have going on to either lessen that or almost, wipe it out.
Yeah. And so, some more on that, and for our audience, they can go back and they can look through our our history listing of podcasts, our playlist, and we did do something early on a while back and talked about stem cells and exosomes, the basics of what are they,
Yeah.
and what do they do. But take us into that a little bit, if you would, Dr. Ethan, on the following, because you said maybe even eliminate these things. So
Hmm.
this is something that, and I hate to call it traditional medicine, but let's say other approaches, other protocols for some of these things don't necessarily offer that hope of healing and getting rid of it. Why do the biologics you use in your approach, why does it offer that hope? And also across the scope of what you do, um, what's that level of hope in each one of those? You mentioned, because we talked about joints, we talked about kidney disease, we talked about other things you do. So take us through the level of hope that people can have using the biologics.
Yeah, so I'll take one of the most common examples. We're going to treat someone that has knee arthritis or knee pain.
Mhm.
And so when someone comes in with those things, I'm talking about all comers to having, mild disease to severe disease. And so the question becomes, okay, one, can this help? And then how much can it help? And so it definitely can. And it does it in the way of saying, hey, we're not going to make new cartilage where cartilage is gone, but we're going to make the cartilage that's there bigger, better, stronger, faster, healthier. Right. So when we do that, now the knee wants to respond better. And also we're going to get rid of the inflammation that lives in that knee. And we know that that joint fluid, we could take it out and we could measure certain factors in there. And they have names like IL-1s and 2s and metalloproteases and TIMPs and all these things that actually cause inflammation. And you can kind of think about it as if your knee was a snow globe, and all those little white flecks in there are these bad things that cause inflammation and pain. But if we go in there and we get rid of those things, then your knee is calm and it feels good, even if there's structural damage of it. And so the hope for those patients that come in that have that particular issue going on, 9 out of 10 people that walk in get some significant amount of relief from what we do for a significant amount of time. Now, that's not a cure. It doesn't last forever. I'm not saying any of those things. Like we'll get you down the road to where that you feel better than what you did, somewhat normal or mostly normal. And it can work very well. That's knees, right? We talk about another joint, it could be less, or we talk about another disease, it could be not necessarily more, but and there's all varying degrees of these things.
When you say for a significant amount of time, what kind of time are you talking about? Because with cancer, successful cancer treatment, sometimes they talk about 3 months of life extension.
Right, right. Yeah.
And what kind of time are we
Yeah.
talking?
On average, 4 years with these things when we talk about certain joints. And that's once again, that's anecdotally what I've seen in my practice. That's also what you see in the literature.
So what do you do after 4 years? Is there anything more you can do for them, or is
Yeah, you can
injury at
You
that
can
point?
you can repeat these things. I think about now at this time, if we were to treat your knee and you're doing better, in 4 years we might have something better than what we have now, right?
Yeah.
And chances are we will. There's definitely, you can repeat it as you go. Maybe it's time for surgery. Maybe it got you home, so to speak.
Uh,
You know, there's several options there.
Tim, I,
Let's. Oh, go
I
ahead, Dr. Bob.
Tim, I have more questions, but I just don't want to dominate the whole thing. So work me in with some of my questions when you can, okay?
Yeah, be happy to. Let's get into some of the tools and techniques that you use, but also let's remind our listeners that there is a great resource for them. Please join the WellWave Now Facebook group. All kinds of excellent resources there. And thank you for listening to the WellWave Now show for all those that have just joined live. Let's get into some of the techniques that you're using and tools.
Yeah. So there's a few ways to approach these things, right? As far as harvesting bone marrow, harvesting adipose, especially when you take it from the patient, doing a blood draw. These are the things that we do. So when we take the adipose, it's like a mini liposuction. When we take the bone marrow, we're doing a bone marrow harvest. And people initially will say, "Gosh, it's got to hurt really bad." It's about a 3 out of 10 on the pain scale, and you really only feel that pain when I'm pulling the bone marrow out. And because it's a negative pressure bone, you feel that 3, but I'm only pulling for about 10 to 12 seconds each time, and I may pull anywhere from 3 to 6 times depending on how much material that I need. So it's very, very doable. I treat a lot of professional athletes, but also treat a lot of senior saints and working stiffs like me and those things. And most of those people would say, yeah, it's very doable, not what I thought it would be. We can give you Valium and Finnegan if you want to kind of make things feel better, but there are times when those professional athletes, because they just don't want those things in their body, they go without those things. And so I just numb them up and take those things, and they do well with it. So those are the main tools that we have. And then we have a variety of,
I
once
love
again.
that. So I know we're going to dive into that
Oh yeah.
whole big toolkit that you've got there. I know you've got a good amount there. But let's take those three: the PRP, the bone marrow, and the stem cells taken either from bone marrow or adipose.
Yeah.
How do you decide which one to do?
Yeah, this is a great question, and this is one that's changed over time for me. Bone marrow has been like it's been, well, I mean, PRP has been with me the longest, but bone marrow is like is the girl that I married. That's
Mhm.
my, that's my ride or die. And bone marrow is my ride or die because it's most like everything that we're treating, especially musculoskeletally, right? And it just does well from all ages. So if I take a 20-year-old versus a 80-year-old, bone marrow will work well in both of those patients.
Okay, so
PRP, mhm,
let's let's go there. Let's and I like this opinion. That's why one of the reasons we've got you on here is because, as you know, out there, you've got colleagues that will say, if you've got somebody, I'm still a young guy here, but if you got somebody as
100%.
old as Dr. Bob, that bone marrow isn't going to do them any good because they've got fewer stem cells. There's no way you can enrich them enough that you can do that.
Uh-huh.
So that way, you either ought to play around with the FDA and go get them some donated stem cells in the US or ship them off to Costa Rica, Colombia, Mexico, where they can do it legally out there because there's no way that their bone marrow is going to give them stem cells that are going to heal them up in that one.
Yeah.
So and you've just said the opposite there. So give us how you found that out and contrast that with that.
Yeah, no, I mean, bone marrow, like I said, bone marrow definitely works. And I always ask people, colleagues, when they have these questions, I said, do you want to be in in a cage with a young lion or an old lion? Which one would you rather do?
I don't
And
know.
yeah, yeah.
No,
And
no lion for me.
exactly, that's the answer. The answer is like, I don't want to be in either, I don't want to be in a cage with either one of them because both of them will get you, right? And it's the same thing with when you take bone marrow from a young person versus bone marrow from an older person, is that both of them still work and they have activity. And now the better question to ask me would say, well, is there a different in the activity of those stem cells?
Yeah.
Probably, no doubt. But like I said, if you're in that cage with an old line, you might cease to be with us, just like you would cease to be with us with because the activity is enough, right? And so, but PRP is different. PRP definitely is more active in a younger person versus an older person. So as I've gone along, I use less PRP in my more older individuals, and I may use something else in lieu of that.
Right. And so I'll give you your question in a second, Dr. Bob, if you would, because I kind of took Dr. Ethan down a Nebraska tangent here, but I'm going to bring it back to his Tennessee roots. And you just gave one reason why you use on that question we were asking why you use bone marrow over PRP because the PRP could be less active for somebody and the bone marrow always has some activity. How else are you deciding between harvesting from the bone, harvesting from the adipose tissue, or then using the PRP?
Yeah. So, adipose is something that is a great resource because one, you can get cushion with it, right? So you have this cushion for a joint.
Mhm.
The interesting thing about adipose is that per volume, so if you had 1 cc or 1 mil, like just, whatever the volume you're going to use, when you compare the same volume of bone marrow to the same volume of adipose or fat tissue, you actually have more stem cells or mesenchymal stem cells in that volume of adipose than you do in that volume of bone marrow. And so you had guys that were bone marrow guys and oh bone marrow, and you had guys that were adipose guys like oh adipose. And I'm probably an equal opportunist in that. And there are times and places where adipose is hard to use, like some of the soft tissue things. But if I'm dealing with a joint and I can use both of them, I'm doubled everything. I've got more stem cells, I've got cushion, I've got all that stuff. And so I like to use those two together in that
Together.
at the same yep, at the same time.
Wow.
And even, but also, you can use adipose with soft tissue. Also, if you got a defect in the soft tissue, adipose can work, but bone marrow works really well. Yeah, if I can get both of them in, I like to do that.
Dr. Bob.
So, Dr. Ethan, where do you put these cells that you get? Like, how do you get them in there? Where do you put them? How do you determine where you should put them? Do they always go the same way, the same place, or are there things that you do to direct where you put them?
Yeah, so that's the fun of being a physician and diagnosing things, right? And understanding the pathology or the pathophysiology to say, okay, in the shoulder, is this coming from their subacromial space because they have bursitis? Or is this because they have a cuff tear? Is this their biceps tendon that's going on? Or in the knee, like is it because they have instability? So I need to think about their MCL or their medial collateral ligament as well as their lateral collateral ligament? Is this all because of the joint and arthritis and inflammation? And so then once you've kind of made that determination and you say, who do I have and what are we trying to accomplish, right? If I've got, one of my NFL guys and I'm trying to get them back in a week, we'll do a little different than someone that I can take a little more time with. And then I'm going to say, okay, well, I need to use this ultrasound to then figure out exactly where I need to put this material. If I think that it's coming from his biceps tendon, or I think it's coming from the facet joint, or where it is I think. So now I'm going to use an ultrasound and deploy these things with needles to the place where I think that the problem is. I want to get it as close to the problem of concern that I can with an ultrasound that I'm using to locate those things.
So one of the biggest problems in our society right now are knees. I mean, you
Hmm.
go to people are wearing shorts like down here in Florida, and you walk around, you see the classic, on the knees, the surgical incision
Yeah.
that was done. And so uh and most of those people would say they were quote bone on bone, but is not one question, is the cartilage really totally gone, or isn't there always some amount there that you can build on? Isn't that why you put the stem cells in there to see if you can build back the cartilage? And then the second thing is, if somebody's really bone on bone and their joint moves and you can hear that.
Snap, crackle, pop. Yeah.
Really, I mean, some people you can hear it when they're walking or they bend down, bend their knees. So how do you can you manage that?
Yeah. So definitely if you're dealing with the knee and arthritis and whether it's bone on bone, not bone on bone, um, those, for the majority, those people can be helped. And like I said, if you're dealing with something like a hip and hip OA, you got to think about that a little bit more or treat that a little more to get to a much better place. It's not the same in a hip as it is the knee. And so the knee is kind of like one big room, and you want to make sure that you cover all of you want to put it in so that it goes all over the room. But then you want to think about instability as far as the ligaments. Do you need to treat those things? And so sometimes you may put some of that in the ligaments to help with stability, right? Because stability plays into pain. When things has micro instability, that's when you have more pain. And then as far as the snap, crackle, and pop, what I have found over time is that sometimes things snap, they crack, and they pop, and there's no pain with it, right? And so if I can help the pain, which is what I'm going after, then that's fantastic. That's what we want to do. And sometimes when you treat them with these things, that snap, crackle, pop can lessen, maybe not totally go away. But once again, as long as their pain is gone, that's really what we're after.
Okay. Well, Dr. Ethan, tell us about A2M. You have it listed on your website, and how does it
Yeah.
fit into your regenerative toolbox?
Yeah, so A2M is one of those things that has come about recently for me. And in fact, and I say recently, there was a couple of years ago that I tried A2M and did not get a lot of success with it. And, come to find out I wasn't, y- using A2M. I wouldn't say that I wasn't using it properly, wasn't being processed properly, right? Sometimes on your continuum of learning, you're better at something than before. And
Mhm.
sometimes if you're using someone that says, oh, this is the thing to use, it may not be the thing to use. And so those things came back to me probably about 5 months ago. There's an orthopedic surgeon actually down in Florida, and who has, I would say, discovered it in some ways. He's a PhD along with the MD, and has the patents on all this stuff, and has his particular way to do it. Anyway, learn those ways. Treated myself with my bum knee from playing my now 15-year-old child in some basketball. And I tried to pretend that I had old man strength and I could still get him. But he made me pay with a swollen knee. So treated myself with this A2M. Literally within 3 days, the pain was gone. And so, for me, like, there's a lot of times when I have to trust either what a patient tells me or what someone else tells me. But now I'm telling myself this, like, man,
Right.
that feels better. And so A2M it's called alpha 2 macroglobulin. It is a protein that is found in our blood, and it's a protein that has four venous flytraps. So if you can think about four venous flytraps that are sitting together, and when you isolate that molecule from the blood and then you inject it in a joint, what it does, and I mentioned earlier that there's a lot of these bad factors, cytokines in the knee that cause pain. like the metalloproteases, TIMPs. Well, A2M will go in there and it's going to trap those bad factors, so it sucks them up into those four spots, and then it ends up being, um, taken out of the joint and then gotten rid of in the liver and so on and so forth. And so it's a natural way to do it. The problem with our joints and things like that is that blood can't get in there to do what it's supposed to do.
Mhm.
And so we're actually bringing that to the situation. But A2M is one of those molecules that it's fascinating because it goes in there and essentially just says, all right, I'm gonna get rid of all these dudes that are causing issues.
Yeah.
And when you get rid of them, even though you still have the arthritis, even though your cartilage is now the one, it's been shown that it can not make new cartilage once again, but help the cartilage that's there to be bigger, stronger, better, faster, just like stem cells, what it does as well. But can reverse their arthritis to some degrees, definitely slow it down. And so it goes in there, gets rid of all the, like I said, these proteases and all these things that are causing destruction, causing inflammation. And when that's gone, then your knee feels better.
And that's the best explanation I've heard about A2M, the
It's
little venous
it,
flytraps.
I mean, it's fascinating what it does.
Yeah, absolutely amazing. Well, another question for Dr. Bob. You on this yet, Dr. Bob? It's helping me with more energy, more focus, and when I chew it, of course.
I need it.
It's NeuroGum, and it's full of natural nootropics and energy focus. Oh, look at that. Dr. Ethan's got his NeuroGum. Good job. Natural caffeine, full of vitamin B12, vitamin B6, and the amino acid L-theanine, also known for improving cognitive function. It's sugar-free, tastes great, and refreshes your body and your mind with NeuroGum. It's available in the TikTok shop and something that I've enjoyed. I've gotten off of those nasty energy drinks that are so bad for you, and I just chew NeuroGum now. So that was fun that you pulled it out too, Dr. Ethan. Showed off that you are
I love it.
I am
yeah.
su- I am sufficiently shamed. I will get that.
I know. The next time that the Dr. Bob dozes off, we're gonna we're gonna inject NeuroGum into him. So now let's hear about what are some some actual results. So some success stories, some patients that you've been able to help them change their lives.
Yeah, I mean, they're the countless, the musculoskeletal things that we have taken care of, and it never ceases to amaze me. I've been doing this for 8 years, and around 3 months is when things really change, especially after having this done. With some of the things that we do now, sometimes that's earlier in the way of, it can happen as soon as 2 weeks. But I always tell people to give me a good 3 months. But when people come in, they say, "Gosh, that feels better." I am always amazed. I've been doing this way, kind of full time. I mean, been out of fellowship since 2014. So this is 2025, so 11 years. So for the last, when I kind of opened what we know as Kellum Stem Cell Institute now, I've been doing this for 8 years, and I'm still, I go, it feels better, like really. And then when they get the length of time that they do, and so there's all the musculoskeletal things that we can talk about: knee pain and knee arthritis, and shoulder pain and shoulder arthritis, and ligament damage, and all of those things. There's the people that had back issues, and you inject it in their disc, and their disc almost looks normal, right? After having things done. They're the folks that are CrossFitters, and they come in and they've got fibular fractures that non-displaced and trying to do their things, and we're able to get those things healed without just stuff. And then there's the patients that we treat with IV, and they were told that, hey, we think that you might have some blood cancer, and we're gonna have to do a biopsy. And you treat them, and then next thing you know, their labs come back and they're all normal. Or the kid that he's had 5 sets of lab, and his thyroid is completely off, and then we're treating him for something else, and then those labs normalize. So they're but the kids that have autism, and now they're saying words, or now they're making eye contact with their parents, or they're now socializing with people that they wouldn't in the past. And so there's all of those things that happen. And I always try to be very honest, and I would never tell somebody that this is it works every time, and all those things. But
I have to interrupt here. You brought up autism again. Are you treating, these are kids, right?
these are kids. Yeah.
What are you treating them for, and what are you treating them with?
Yeah, so stem cells, growth factors, depending on what's going on with them. And
putting these.
yeah, so we do those things intravenously, so IV. They are, we could get into a lot of the pathophysiology of how these things work. And, when you put them in the IV, they go to the lungs and then do they leave there? And well, do you put it intrathecally? Do you put it intranasally so it can get there? There's a whole host of how to do those things, but that's how what we do for those
Last
children.
question about the autism thing. So if you had 10 autism young people coming in and you did treatments for them, how many would you see improvement in?
All of them see some sort of improvement.
Always, yeah.
But there's a variation of the amount.
Uh,
All of, at least I would almost say that all of them see something from what we've done. Now, does it get us where we want to go? That's a whole nother question, but the far majority of them have some
Ben,
benefit.
one last,
So,
think it's working. How do you think they're working?
Once again, I think they work by modulation, by modulating the immune system
Okay,
and decreasing inflammation.
information.
Yeah.
super.
So, a couple things. One, when you were talking about sort of the musculoskeletal issues,
Hmm.
and you were saying people can start looking at improvement and good things in 3 months or so, sometimes. And then when you're talking about the thyroid and the autism and the other things, how soon can people look to say whether or not, if nothing happens for a month as these stem cells and others take root, are they done, or are they say, boy, give it another 2 months, like we do in the musculoskeletal, to start determining whether or not it's working for you or not? What type of time range do you think works in that world?
Sometimes if you're doing it IV, you expect to see something a little bit sooner, but it's still it's still the same time frame. Like give us because there's an effect that happens that can happen over time too. I tell this story a lot. One of the first times that I injected someone's knee here in Nashville, Tennessee, this lady was a runner and she was from around my hometown in Jackson, and so she had gotten out 7 months.
Mhm.
And I'd seen her at the 6 month point, not doing great. Like I said, there is that percentage of people that just don't respond to this. I was on an airplane and my cell phone rang and it was this patient. And she said, I just ran 2 miles and it felt great and all those things. And so that was 7 months after we had, done her procedure. So sometimes it takes a little bit longer in people. Sometimes it's hard to overcome the inflammation that they have going on. But, once again, it's not a cure. It doesn't last forever. And some people just don't respond well to
Right.
these things.
So am I right in my layperson's point of view here in the following? Is that sometimes in using the stem cells, you're looking for them to grow up and be things like the normal thing, like a stem cell. Maybe it is supposed to help in some ligament repair, and they're supposed to add on to that ligament. But it sounds like to me, in other cases, you're looking for these biologics to have, and like you said, the Venus tritype, grab things, impact things. So you're getting both there, and so then depends. So some of the time frame depends on what you're trying to do there. If you're looking for the stem cells to grow up and become something, they're going to take a while, right? If you're looking for A2M to start snatching up all the bad stuff in Bob Levine's body, that could happen a little sooner. Is that fair?
No, that's 100% fair. And the thing that I would add to that is that the sexy part of that is the first part, right? Oh, it's going to become this, it's going to do this.
Right.
But really, the majority of how it works is that second part,
Right.
the not so sexy part. But you're exactly right in your understanding of that. Is like, okay, well, these things can become the tissue, but it's really about decreasing the inflammation and the tissue works better and all of those things.
Okay. Sorry, Breck, but well, as I said, I'm not quite up at Bob's age yet, but I'm getting there and it's starting to hit my memory. So if I don't put this right in there now, I'll forget to ask this question. Because we took Dr. Ethan down his toolkit path, but we talked about A2M, PRP, whether you extract the stem cells from adipose tissue and bone marrow, different things you can get out of those. Anything else in your toolkit that you want people to understand that you're using or experiment? Not I won't say experimenting with, but
Yeah.
trying to
Utilizing.
explore.
Mhm.
Yeah, I mean, there's a lot of things out there. The big things that I'm going to talk about are things that are that are super easy that people will want to gloss over, right? What we eat every day. If I use that on one patient, as far as her, she lived in Nashville part-time, lived in Minnesota. She was in the summertime. She was in Minnesota when I had the consult with her, and
Mhm.
she's coming back to Nashville. Hey, my knee pain, my knee hurts. You got my X-rays? Yes, ma'am. I see why your knee hurts. You've got arthritis. What can we do about it? Hey, we should do this and this. And as I talk to her, I say, if you can get rid of, these 7 things in your nutrition, dairy, sugar, soy, soy, peanuts, eggs. That's a little controversial to say eggs, but if you can get rid of these things, this is going to help us in what we're going to do, right? By the time she comes to see me in the fall to have this procedure, she's like, my knee feels pretty good. I don't think I need anything done. But she had took to heart those things that I told her. So nutrition is going to be one of those things. But then there's things like hyperbaric oxygen, I think that can be super helpful. Potentially things like ozone. There's PEMF that's out there, and I'm sure these are all the things that you guys look at and enjoy and believe in. But all of those things to some degree can be super helpful. Just with, once again, lessening the disease burden by getting rid of the inflammation. So there's sauna that you need to do it 4 to 7 times a week, but those things, all those things can be really helpful.
Yeah, you've hit on things. Like we've got for our audience, we've had a podcast on the hyperbaric, the HBOT, hyperbaric oxygen therapy and medical grade and what that does. We've had a person on related to we've had some food as medicine that's done some things as well, but also related to to that sort of nutrients. We've had a real good guy named Armand Eckelbacher on talking about supplementation. IFBB person in his
Hmm.
60s, still in his 20s physically, and what that does. And he's given me some things that have helped my knees tremendously that I put on that were just supplements like MSM, Boxwillium. What else we added? We had a couple
Yeah.
other things that I think have done tremendously. And yes, all three of your people here with you today, we use PEMF. We've got to get Dr. Ethan using that PEMF too.
I have a Mac.
Really?
Yeah. Yeah, no,
Yeah.
I believe in that, and even some of the newer technology. I don't know if you've seen any of the RF with the high FEM, and
Yeah.
that combination can be really good for musculoskeletal things.
Yeah.
And so looking into that heavily because
Yeah.
it
There's a
works.
yeah, there's a new player on that high frequency line that's out now in its trial phases. It's having some remarkable
Hmm.
results on.
Yeah, that's excellent. All really good information, good techniques, and all things that we have covered on our podcast series. So invite every one of our listeners to go back and listen to previous podcasts because we've done one on each one of these topics, which is amazing. So, Dr. Ethan, how is regenerative medicine? How is that going to fit into the future of healthcare? And is it complementary? Is it a disruptor? How do you see it fitting in?
So I think that I think that the future that we're going to do that more and more. And I say the future like relatively quickly, and actually we've already done some of it, right? And so I think that as we go, it is going to just be more and more to the point that you take something like an A2M. A2M has something that's worked so well that now a drug company says, well, if we can make that synthetically, right? And so we may know A2M or wherever out, however it looks when it comes out as a drug, but really that came from the very natural form. And so I think that we're going to go more and more into that, and you're going to see more and more fields. Oh, we got regenerative orthopedics over here. Oh, we got regenerative cardiology over here. Oh, we got regenerative neurology over here. I think that people are going to adapt that more and more as they see more and more of these results. And then, quite honestly, there's going to be so many new things that are coming down the road just because we are. Um, I mean, we are the smartest that we've ever been, and so it's going to be an interesting thing.
Do you think, real quick, Dr. Bob, do you think that insurance is ever going to adopt covering some of these techniques? And you got to think about it, right? Because you literally have the ability to help patients not only live longer, but healthier without the pain. So is that going to require actuaries to come in and change the lifespan of someone when they're providing insurance quotes?
Yeah, this is a real tricky question, and I'm gonna kind of tiptoe around it and just say the positive things that are here because I think that there are some insurances now that cover these things, and they normally cover in the form of there has been a higher up that either owns the company or runs the company and happens to do the insurance things, and and normally they say, well, I'm going to have this because I don't want to do surgery, and or what have you, and they have it and it works for them, and they go, well, and then so they decide to put that on their plan, right? So you have some of those Blue Cross Blue Shields out there, self-insured people that cover these things. That's not a part of the very general offering of Blue Cross Blue Shield or any of those things. And so once again, there's some insurance companies, and they also understand not only the impact of, hey, this helps, right? But for them, not only does it help, but there's also an economic impact of that too. To pay 1/10 of the cost of like a surgery to have a person that will not, that doesn't have to be out of work for 3 months, who may not come back, is way more enticing to a business owner or a professional than the other is.
Yeah. And Dr. Bob, I think, has a question for you, but he's on mute.
Oh yeah, Dr. Ethan, you hit the nail on the head. It's the self-insured larger companies that are really going to be interested in including this because instead of, like you say, instead of paying for a surgery, they're going to be paying for this procedure, which is a fraction of the cost.
Mm-hmm.
So another question though, let's just take knees, hips, and shoulders.
Yeah.
Longevity, like after the treatment, where do you, in your expertise, where do you find the most longevity for people getting the benefit for the longest period of time? Is it in
Between those two joint or three joints?
hips and shoulders? Those are the main ones people are
Yeah.
doing, right?
So, so knees are in that 90% for those 4 years, right? And so there's obviously some people that are more than those 4 years, right? There you can see, it could be 7, 8 years down the road. Shoulders are going to be next, and that 70 to 80% are going to get that road. And then hips,
4 years.
4 years, yeah. And then it's going to be 50% of those people that are going to get those things. And one of the things that I have to think about as a physician, as I treat those people, because what I'm telling you, the stats that I'm telling you about those joints so far for length and the percentage has to do with us doing one injection,
Mm-hmm.
right? One treatment, and you get that amount of time. I think one of the things for me that I'm going to have to look at closely is to say, okay, I know that hips are tougher, and now I'm going to bring them back and I'm going to do 2 injections, or maybe it's 3 injections to see if I can get to a much better place for longer than what I have in the past.
When I've had both of my hips replaced from my football and skiing injuries and beating myself up. And in one of the hips, it was way worse than the other one. They couldn't even pop the head of the femur out of the socket. They had to hammer and chisel it out for
Yeah,
15 minutes to get it all out of there.
so deformed.
I'm presuming that there's no way that the stem cell approach could help something like that. Is that a
Yeah, I mean, it's a little tougher as you get something like that. And right now, where I live, I would tell someone if they had a hip that looked like yours, I say it's probably better for you to get, to have a hip replacement done.
yeah, I didn't see any way that I mean, it was just crazy how they had to get the hip out of there. Anyway,
Yeah.
Well, so we've talked about a number of all the good things and the possibilities and results on them. What do you caution your patients about as you look at this to say any downsides, any contraindications? Well, you talk about a contraindication there. Hey, if it's that bad, it's all solidified, it might be time to replace this. I still think that's the surgeon coming out. And yeah, I mean, if you went full regenerative, you'd say, let's put that in there and we can still get some help.
Yeah. Well, so yes. And so there's the biggest thing is that this may not get us where we want to go. And so you're trying to look at the patient, trying to look at their imaging, trying to understand what they want to do in life, and understand where your successes in the past have been with this particular joint, and then saying, hey, um, do we do this or do we not do this? Right. And there's sometimes when I straight up will tell a patient, like, I don't think this is going to work for you. And like, well, you know what? I'm not going to have that total hip done, or I'm not going to have this whatever done, and you're going to do this for me.
Mhm.
Okay, because there's very little downside into that other than time, effort, and money,
Yep.
right?
Yep.
It's not going to hurt you for the most part and all those things, blah, 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 blah. And so, like I said, there's times when I tell a patient like, nah, no, or there's a lot of times that patients have taught me things too. I never forget I had this military guy that had been, he'd been hazed in the military. I know a lot of people don't think that happened. My brother's in the military. I, you know, I'm appreciative and thankful for our military, all those things, but he'd been hazed and he had these very non-specific spots on his chest that hurt. Got an MRI, nothing lit up on the MRI. And this was early on in my time here in Nashville. And I said to him, I was like, I don't think I don't think this is going to work for you. I don't think this is for you. And I was very much in my surgeon kind of way of like, okay, nothing's broken. So what am I going to fix here? And so he was very adamant about me treating him, and he got better. And that, that took me a long way in understanding that, hey, sometimes one, the patient is going to tell you what's wrong with him. Two, that imaging doesn't always show you those things. And once again, it doesn't hurt to try at times. I had also another patient early on here in Nashville that said, I have, X-ray findings of arthritis, mild arthritis, but I don't have any pain. And I think you should inject this preventatively. Now, this was 8 years ago. And I looked at her and I said, no, I'm not interested in doing that. Now, if you ask me that same question today, I'd be like, by all means, we'll inject that. But she was ahead of the time than I was at that time. All the racehorses in the Kentucky Derby have been injected with PRP, all their joints.
Mhm.
They don't have any issues, but they know that that's going to keep their joint healthy.
Okay.
Yep.
My pleasure. Well, I didn't give you a WellWaveNOW hazing. I gave you a WellWaveNOw ribbing about the surgeon. A little tangent. That's because some surgeon told me when I had what you call a little arthritic cast off, the ganglion cyst.
Hmm.
And he said, want me to go in there? I go in there and I can just fix this thing right now. I need to clean this. I need to clean that whole knee up. I said, no, my other knee's worse. I said, well, I'll take care of that one too.
Yeah.
And I went 10 years before and it really got any worse on me. But so that's why I like to rip the surgeons sometimes.
Oh, for
But
sure. Yeah.
I'm gonna flip the coin over and really give you a lot of applause as well because what you said is where you provide a service to your patients, where you take that time, like I said, to learn from them, but also where you brought up the part about the dietary portions of this and understand how it impacts that. You've really got a nice total 360 view that you're bringing there to really complete health to address it that fits with our philosophy and what we've learned out there that works for the
Yeah, that's
project.
been amazing. Thank you for that. And there are many people listening today that are dealing with a chronic condition or degenerative issue. Is there one other thing that you didn't cover that you need to cover? What's the one thing that people that are dealing with those conditions need to know?
Yeah, I mean, I would just encourage people as you guys do, what thinking well, resting well, eating well, relating well. Those are the things that are going to keep you well. And I'm now 48 years old, and I think to myself, I go, man, how did I get to this point of 48? I'm past midlife at this time on average by 8 years. And so it's, it goes by in a hurry, but if you can slow down and do those things, eat well, relate well, sleep well, you can even add pee and poop well. I think if you're eating well, those pee and poop well, that comes secondarily to those things. But that's what I would tell people, and do that for yourself because no one else is going to do it.
Yeah.
Um,
Doctor, with that kind of thinking, you're not halfway yet.
Maybe, yeah, hopefully not.
Right.
I took so we can get on another podcast. I do peptides, and I'm sure that you guys have thoughts about that. But I took some epitalon years ago, about 7, 8 years ago, before I started prescribing them for patients. But I just did a spectra cell test to look at my telomere length, and it
Yep.
says that I have the telomeres of a 2-year-old.
Ah,
Now, and
Wow.
I don't know, maybe the test is wrong, but I'm gonna tout that.
I
I'm
would
like,
definitely get another test. Just to,
And so for our audience out there who isn't really completely into the longevity and the measurements on that, as one of the measurements one of the people tout is how the length of the telomeres also, kind of provide an indication or a marker of your biological age there. So the longer they are, then you're good. And now I could see Breck and Bob. I wasn't going to go there, Bob, but you brought it up. You got me there. I can see them biting their tongues. They know every time somebody mentions lifespan, I come up with my standard thing, which is biblically and scientifically, the lifespan is 120 years.
Yeah.
And there's the Moses plan, where Moses was 120 years old and climbed that mountain on the 120th, on that 100, at that year 120, and then died after he climbed the top of the mountain. Not as a result of the exertion, but he could still do it. So at 48, you're not even halfway there yet.
We're good. We're good.
Get you to 120.
I just got to keep doing things well, right?
Right, that's right. And the challenge is, and what I think what you're helping with, what you brought out here today, and the preventative and regenerative, and what we try to do is how do you get there? And then also, how do you get there with the mind and body that you want to have at that time?
Right. Yeah. I want to die young, but not tomorrow.
That's right.
Yeah, exactly. Yeah, we definitely need to have you back on another podcast.
Oh yeah.
Right. So until we do, with all the success that you're currently having, you've laid out quite a bit there, the thyroid, the knees, the joints, helping the Celtics. Now you've helped the Celtics in the past. And so I'll let you go on that. I've been a Lakers and a Bulls person, but we'll let you go on helping the Celtics that way. And you're helping the Titans now, which is good. But and then you're helping still, as we went through every number of everyday people, both athletic in general, but also just want to live better. How do those people reach you? Because it sounds like you're helping people from across the country. Let's help you help more people from across the country. And get some Europeans and others down.
Yeah. Yeah. You definitely, there's Kellum Stem Cell Institute. You can find me there. Every patient has my cell phone. So I put that out there. People are happy to call that 901-484-0837. I say call. I probably prefer text better. But
Okay. That again,
yeah. It's 901 484-0837. And then of course, there's Kellum Stem Cell Institute, and you can find us there too. So
really, really great information, and I acknowledge you for the work you do and the clarity of your communication, making it, bringing it not down, but bringing it appropriate for all of us, the three of us, and all the people who are listening. So
thank you, Dr. Kellum. It's great to have you on, and definitely going to have you back. I know you
appreciate that.
So appreciate you taking time out of your busy schedule to share your expertise and your vision with us today. And to all of our listeners, we remind you to stay curious, stay empowered, and always continue looking and chasing wellness, right? Be sure to subscribe to the WellWaveNOW podcast if you're not already, for additional expert conversations. And then please visit wellnesswaveclub.com. That's our official website for the Wellness Wave Club. And, more tools, resources, and everything to help you thrive. And always remember, wellness, it's in you.